Hello, and welcome to a very special episode of Ventilators Made Easy. I'm your medical director, Dr. Jones, and I'm coming to you live from the heart of the Gator Nation, the University of Florida. Now, if you're like me and you've ever sat through a ventilator lecture, they're usually really terrible, which is a shame because ventilators are fantastic devices and they're not that complex. But the lectures make them seem like they're impossibly complicated with hundreds of settings and millions of buttons. It's just not true. So, our hope for today is you come away from this lecture saying, I know how to rock the vent. I am completely comfortable taking care of any patient in my rescue unit on a ventilator. So, without further ado, let's jump in. What's cool about this lecture is it's not device specific. So, whether you're taking care of a patient on this, the simplest of transport ventilators with just a couple knobs, all the way through this, the complex ventilators we use in the ICU, the principles I'll teach you in this lecture are universal. And as long as you follow them, you'll be able to take care of any patient on any ventilator, at least for a couple hours. So first, some ventilator basics. What do ventilators do? Well, no matter the device, they're going to push air into the patient until they deliver us a set volume or they hit a set pressure. They're fairly dumb devices, even the ones we use in the ICU, and so they need you to be smarter than the machine. Because they're not going to tell you what to do with your patient, and they're not going to know how to fix your emergency. They may beep and boop and give you alarms, but they don't know exactly what's going on with your patient, and you do. All right, 3 quick pearls of wisdom that'll make using ventilators easier. Number 1, I want you to remember that intubated patients are trouble, and we really try to avoid intubating patients unless they absolutely need it. Because we know that if you could fix the problem with CPAP or BiPAP or oxygen by face mask, and you didn't and you went straight to intubation, most of the things we care about for the patient are worse, including hospital length of stay, morbidity, mortality, and generally, your odds of just coming out in a good condition from the hospital are worse if you were intubated unnecessarily. That's likely because the brain is really good at controlling every second of the day how deep and how frequent to breathe, micromanaging your pH and your oxygen and your CO2. And when we take away the patient's breathing and breathe for them on the ventilator, we have to replicate that with this dumb machine. Number 2, remember that when you do have to intubate a patient, the act of intubating them didn't fix the problem. You haven't fixed whatever disease got them intubated in the first place. And the classic saying is you've done nothing to fix the problem, but now you're managing it through a 7mm tube. So just don't forget to give them all the same therapies that you would have given someone in the same condition if they hadn't been intubated. Number 3, everything you want to do on the ventilator works better with good sedation. A sleeping patient is a happy patient. All right, enough of these pearls. We're on to the main event. So the key question now is, how do I use the ventilator? How do I get really good at taking care of patients on the vent? Well, the easy answer is you just have to learn every single mode that comes on every ventilator, and once you know each of them in and out, you're finally qualified to take care of patients on the vent, right? No, that's a terrible idea. The deal with ventilators is that they're actually pretty easy to learn. They're hard to master because vents often have dozens of modes and hundreds of settings. But the trick is that each mode really has only minor advantages over other modes. And it's pretty unreasonable to try to learn all of the various modes on the vent. So instead, our strategy is to become kung fu masters of just one mode. And in this dojo, there's only one mode. And that mode is assist control. What's cool about assist control is that it's on pretty much every ventilator on the planet. So if you need to set a mode and you find yourself in Florida or Texas or Minnesota or New York or even Paris, France, turn on the ventilator, set it to assist control, and you're set. What is assist control? Well, it's a pretty simple mode. It's based on the idea that you set the volume you want delivered with each breath, and whether the ventilator starts the breath or the patient, the machine takes over and delivers that volume of air as often as you specify. You should know that the machine's not that smart. So even if your patient has a tension pneumothorax or only half a lung, it's still going to give the same volume that you set. Now, while assist control will work as your mode for all your patients, once you set that mode, you need to decide your strategy. And there are only 2 strategies. So when you meet the patient, decide which group they fall into. The first group is the lung injury prevention group, which is just every single person who doesn't fall into the second group. And the second strategy is the obstruction group, and that's COPD and asthma. And I don't mean just having COPD and asthma. This is the person got intubated specifically because they were suffering from critical COPD or asthma with really bad bronchoconstriction. So to understand the first group, the lung injury prevention group, you should understand this principle, that injured lungs are baby lungs. And most people going about their day have normal lungs. They take deep breaths, and you can see on the CT scan all this area that's open and available for gas exchange in the lungs. But the patients that we intubate and put on the vent often don't have normal lungs. They often have lungs that look more like this, and whether this is pulmonary edema or pleural effusions or pneumonia or just schmutz, they have a whole lot less room to fit that air into. So what happens if the ventilator tries to force too much air into lungs that are sick and can't handle that much volume? Well, the good alveoli, all those millions of little air sacs, they stretch, they get hurt, and if you force it enough, they can even explode. The injured alveoli, the ones drowning in that fluid, never even see that air. And probably most concerningly, you can cause something called ARDS. ARDS, or acute respiratory distress syndrome, is a horrible ventilator-associated condition where the patient's millions and billions of little alveoli get irritated and edematous and fill up with fluid, and it makes it really tough for that patient to transmit oxygen from lungs to blood, and it's often fatal. What's tragic about ARDS is that we often do it to our patients with bad ventilator settings, with breaths on the vent that are too big. You know, we've been studying ARDS for 40 years, and in all that time, the only thing we found that prevents ARDS is small breaths on the ventilator. And in particular, the magic number is 6 to 8 mLs per kilo of ideal body weight. So to protect your patient and prevent ARDS, remember, low tidal volumes save lives. And since any patient on the ventilator is at risk of ARDS, we make the lung injury prevention group our default ventilation strategy. Okay, so you hook the patient up to the vent, you've turned it on, you've set it to assist control. Now what? Well, no matter how sophisticated your vent, there are only 4 buttons, 4 settings that really matter and do about 99% of the heavy lifting. And if you set every other button on its default setting, you'd probably be fine. But you have to get these 4 right. And the 4 buttons that matter are tidal volume, respiratory rate, fraction of inspired oxygen, FiO2, and positive in expiratory pressure, or PEEP. Button number 1 is tidal volume, and tidal volume is just the size of each breath. What you should know about tidal volume is that this number is just set to protect their lungs, to prevent ARDS. It's based on their ideal body weight, which is based on their height, and so the number that we set in the field should stay the same in the ER, should be the same in the ICU, and even if they go to a rehab hospital weeks later on a ventilator, their tidal volume should still be the same. Do we use tidal volume to address minute-to-minute ventilation? No. We just use tidal volume for lung protection. You should know that most of the bad things that happen on a ventilator happen because someone picks a tidal volume that is too big. Probably the most important setting that you're going to set on a ventilator is getting the tidal volume right. And the trick is set it low and forget it. Pick the right number and leave it there. Don't be tempted to change it. Don't be tempted to turn it up. And the magic number is 6 mLs per kilo of ideal body weight. The cool thing about using ideal body weight is that it's based on the patient's height, not their weight. So whether the patient's cachectic and emaciated or has ballooned up to 500 pounds, their lungs don't get any bigger or any smaller. All right, this is the only part of the podcast that requires a little bit of math. This is how I do math. I write the problem down and then I cry about it. But we need a little math because we need to be able to calculate ideal body weight. And again, what's cool about ideal body weight is it's based on height, not actual weight. So if you have 2 patients who are both 5 feet tall, one is 40 kilos, one is 400 kilos, they are the same ideal body weight. There are a lot of formulas, but the easiest one for ideal body weight is this. You get 50 kilos for being 5 feet tall. You get 50 kilos for showing up. And for every inch over 5 feet tall that patient is, they get 2 extra kilos of ideal body weight. That's it. But if you're stressed, you can't remember the formula, think this. At this height, what would a supermodel of the same height weigh? A supermodel with almost no fat on their body. Use that number, multiply that ideal body weight by 6 or at most 8. That's your tidal volume. Set that number and don't change it. So to summarize the first button, tidal volume, it's just used for lung protection. To recap, your in tidal is too low on the vent. Do you change the tidal volume? No. Your in tidal is too high on the vent. Do you change the tidal volume? No. Your pulse ox is too low. They're hypoxic. Do you change the tidal volume? No. You set that number and forget it. 6 to 8 mLs per kilo of ideal body weight. That's the number they keep. And if you are struggling with the math, there's a table in your protocols. There's often a table on the side of the vent that tells you at this height, this is the tidal volume. So you may be asking, if I can't change the tidal volume, how do I make sure my patient's getting enough ventilation on the vent? Well, that's where the next button comes in. Well, I can't change the tidal volume, and I want to get my patient more or less air. Which button does the trick? It's this one, respiratory rate. So button number 2 is respiratory rate, and it's used to control minute-to-minute ventilation, and it's by far the most fun button to play with. So what you do is start at a number like 16, and turn that number up or down, trying to keep that in-tidal CO2 in that sweet spot between an in-tidal of 35 and 45. If their in-tidal is a little too high, turn it up a little. If their in-tidal is too low, turn it down a little. You should also remember that this is the minimum rate. So if you've set it to a rate of 16 and the patient wants to breathe 40 times a minute, they can do that. You're just telling the machine, this is the slowest that I want my patient to breathe on the vent. And the cool thing is, patients usually tolerate really big swings in respiratory rate with no trouble. So feel free to set it to keep that in-tidal in a good range. So to recap, our button number 2, respiratory rate, is used to control ventilation. The third button, FiO2, is probably the easiest. This is just what percentage of the air that we're giving our patient is oxygen. And your strategy should be, for the first 5 minutes, set it to 100% oxygen. That's just to fix whatever low levels of oxygen might still be left in the patient from when they weren't breathing so well or when they were getting intubated. After that, you may want to turn it down to save yourself on some oxygen. A general guideline is something in the high 90s is a really good number, but if you don't get the chance, that's okay too. Also, if you don't have a good pulse ox reading, you can't exactly tell what their sats are, just leave it at 100%. So, to sum it up, our third button, FiO2, controls oxygenation. The fourth button, PEEP, or positive in-expiratory pressure, is just how much extra pressure or air you want to leave in the lungs at the end of exhalation. There's a lot of confusion about PEEP, but I think the simplest analogy is to think about a balloon. Now, when you first try to blow up a balloon, it takes a whole lot of force to get the balloon started, but as it inflates just a little bit, it gets easier and easier, and then once it stays inflated, it's very easy to expand and contract the size of that balloon. PEEP is like leaving a little bit of air in the balloon so that it makes it easier to inflate it and deflate it when you want. The lungs work in just the same way. PEEP often gets a bad rap, which is really unfair because there are a lot of benefits of PEEP. There's one drawback, and there's one big fat myth. The benefits of PEEP are, by keeping a little extra air and a little extra pressure in the lungs at the end of exhalation, it opens up parts of lungs that wouldn't have previously been open. And by doing so, it increases the amount of gas exchange, the amount of oxygen that those lungs are able to transmit to the blood by keeping those parts open. And like the balloon analogy, by keeping extra parts open and keeping the lungs a little bit inflated, it makes breathing effort easier for the patient on the vent. The only drawback of PEEP is that by keeping those lungs a little bit extra inflated, there's a little bit less room in the chest to get blood back to the heart, and so sometimes having a high PEEP will cause low blood pressure or decrease the patient's blood pressure. The big myth that you'll hear about PEEP is someone will say, well, I had a patient on the vent, and they had a big high PEEP, and they got a pneumothorax. It's just not true, and it doesn't make any sense, right? So why would having a little extra pressure in the lungs at the end of exhalation cause a popped lung? Makes no sense. Why did that patient get a pneumothorax? Because the tidal volume was too big, and they were trying to force in breaths the patient couldn't fit. And of course, PEEP also doesn't cause the patient's head to explode. So what's our strategy with PEEP? Well, start at a number like 5, and consider going up or down and seeing how the patient does. In particular, PEEP is really good in tandem with FiO2. So you've got a patient where you've cranked up the FiO2, and you just can't get their sats up. Consider going up on the PEEP, because as you open up those different fields of their lungs, they're able to do better gas exchange, they're able to breathe easier, they're able to transmit more oxygen to the blood, and their sats go up. Conversely, as you go down on the FiO2, consider going down on the PEEP. PEEP, in a nutshell, facilitates oxygenation. So those are the critical 4 buttons you have to get right on the vent. To recap, tidal volume does lung protection, picking a low and appropriate number and keeping it there. Respiratory rate controls your ventilation, going up or down and targeting it to your end-tidal CO2. FiO2 does oxygenation, and PEEP facilitates that oxygenation by keeping the lungs open a little bit at the end of exhalation. You are now a master of the lung injury prevention ventilator strategy. But in this dojo, you must also be prepared for the obstruction group, COPD and asthma. And the core principle for this group is give COPD and asthma time to exhale. In both of these conditions, when they're severe, they have no problems getting air in, but they are working so hard to get that air out because of bronchoconstriction. For you or me, it takes about 3 times as long to exhale as it does to inhale. But in COPD and asthma, this can often be 5 or even 10 times as long. So what happens when, before the patient's able to get out their full breath, the ventilator starts pushing more air in? Eventually, the pressure mounts, and the ventilator acts as a tension pneumothorax machine. So give that COPD and asthma patient time to get the air out. Since we know that patients who've been intubated for critical COPD or asthma need a lot of time to get that air out, what do we do differently? Well, let's think about the 4 buttons. So in this obstruction group, what's different? Is tidal volume any different? Nope. Set it low and forget it. FiO2, same strategy. Start at 100%, titrate down to the 90s if you can. What about PEEP? Same general idea. Start at 5 and titrate to effect. That leaves us with just one button, respiratory rate. And what's different in this group is you're going to go a lot slower. So start with a number like 8 or 10, and your goal is to give them lots of time to exhale between breaths, to get all that air out before more air is forced in. Your strategy is that although you want a rate high enough that keeps their sats up, you want it low enough that they can get all of that air out slowly before the ventilator forces in a new breath. Forcing air in before air can get out is called air trapping or auto PEEP or breath stacking, and it's very dangerous. The downside to this slow respiratory rate strategy is that it causes CO2 to build up in the blood. We call it hypercarbia, and your end-tidal CO2 might be really high, 50s or 60s or more. It's uncomfortable for the patient, you need good sedation to keep them nice and sleepy, but it's not dangerous if they've already got a tube in. The saying is, hypercarbia happens. It's uncomfortable, but it's much preferred to causing breath stacking in pneumothorax. Now hypoxia, that'll kill you in minutes. But hypercarbia just happens. So to recap, we have 2 strategies on the vent. The lung injury prevention group, which is everybody who's not in the second group, and the obstruction group, folks who got intubated because they had critical COPD or asthma. And the main difference is you need to go slower in the second group. 2 quick cases to show you that you really do know your stuff. So case 1, you've got a 5'10" man. He was intubated as part of a trauma alert. He wasn't intubated because of COPD or asthma, so he's in the lung injury prevention group strategy. How do we set our ventilator? Well, the mode, assist control. Tidal volume, if you remember, is 6 to 8 mLs per kilo of ideal body weight, which is calculated at, you get 50 kilos for being 5 feet tall, and you get 2 extra kilos for every inch over 5 feet. Since he's 5'10", that's 50 kilos plus 2 times 10, which gets him 70 kilos. You multiply that by 6 to 8, and your tidal volume is somewhere between 420 and 560 mLs. Respiratory rate, since he's in the first group, is 16, and titrate up or down to a good end-tidal CO2. FiO2, start at 100%. Try to eventually titrate down to something where the pulse ox is in the high 90s. And lastly, PEEP, we'll start at 5 and titrate up or down as needed. That is it. Case 2, you have a 5'4" tall woman. She was in respiratory distress with COPD, became obtunded, and got intubated. She is in the obstruction group. Her mode, assist control. Her tidal volume, again, 6 to 8 per kilo of ideal body weight. So 50 kilos for being 5 feet tall, plus 2 extra kilos for every inch over 5 feet, which comes out to 58 kilos. Multiply that by 6 to 8, and her tidal volume should come out to 348 to 464 mLs, somewhere in there. Respiratory rate. This is what's different. You gotta go slow because she's COPD. So start at 8 or 10. You can titrate up cautiously, make sure you keep her sats up, but you wanna go slow and get all that air out. FiO2, start at 100%, try to titrate down if you can, and PEEP, again, start at 5, titrate up and down as needed. That's it. So now that you have ventilator settings down, let's get to troubleshooting. Let's say your COPD or asthma or any patient on the ventilator all of a sudden goes crazy hypotensive, or gets really tachycardic, or becomes profoundly hypoxic, or even goes into complete cardiac arrest. What is the very first thing you do? So what do you do, hotshot? What do you do? Do you listen for lung sounds, checking for attention pneumo? No. Do you needle decompress, just assuming they had attention pneumo? No. Do you check your vent, see if you've got bad settings? No. Do you call medical control? No, absolutely no. The first thing you do every time is disconnect the patient from the vent and open that ET tube up to air and let them exhale. Because what's really likely is they were breath stacking. They had air that was being forced in that they just couldn't get out. And if you let them exhale, a whole lot of the time, you're going to fix what's wrong with them. After that, most ventilator problems can be solved with the mnemonic DOPES. And I want you to memorize it. It stands for dislodged, obstructed, pneumothorax, equipment failure, and stacked breaths. And honestly, of these 5, stacked breaths is the most important, but SIDOPE is a stupid mnemonic, so it's DOPES. All right, let's run through DOPES. So to check if the tube's dislodged, you can take a quick look with your laryngoscope, see if it's going through cords. But if you don't have a good and consistent in-tidal CO2 waveform, you're pulling that tube every time and reintubating if needed. Obstruction, and we're talking about obstruction inside the tube, you can suction with a whistle tip catheter, but if you can't fix it, sometimes they're so gunked up, you just have to pull the tube and reintubate. Pneumothorax, listen, find out which side the pneumothorax is on, needle as needed. And if anybody who has a pneumothorax can't go back on the ventilator, they have to be hand bagged. Equipment failure, so you can quickly check your vent settings, make sure you've got low tidal volumes. Any doubt, you can always go back to hand bagging. You can intuitively feel better than the ventilator can figure things out. And lastly, always rethink about breath stacking. When in doubt, disconnect from the vent, go with even smaller tidal volumes, that's 6 per kilo, and consider a low respiratory rate if that doesn't work. So to sum it all up, turn on the vent, set it to assist control, figure out if your patient is obstruction or lung injury prevention group, set a good tidal volume, 6 to 8 per kilo of ideal body weight, titrate up and down on your respiratory rate, your FiO2, and your PEEP as needed, go slow on your respiratory rate in COPD and asthma. When somebody crashes suddenly, disconnect them from the vent and allow them to exhale because they were probably breath stacking, and then when in doubt, run through your DOPES mnemonic. Now, for extra credit, if you're especially savvy, you may be saying, but Dr. Jones, our ventilators are fancy. They don't just do assist control, they do a mode called SIMV. But what's cool is if you use all of the same principles I've taught you for assist control, you can run SIMV exactly the same way. What is this mode called SIMV? Well, it stands for Synchronized Intermittent Mechanical Ventilation. It's a comfort mode. And so what it does is, just like assist control, it provides automatic, involuntary, regularly scheduled breaths, but on top of that, it can sense when the patient wants to breathe, and it assists with those too. So patients like it because it's pretty comfortable. But if you understand assist control, SIMV is just extra comfort, extra icing on the cake. So the SIMV mode is just a fancy extra feature of our ventilators, the Newport HT70 Plus, for patients who enjoy breathing. Thank you guys so much for listening. I hope you enjoyed it, and I hope you feel a lot more comfortable working with ventilators. Any questions, email me at jasonjones@ufl.edu. And remember, what you do really matters. With that, until next time, this is your medical director, Dr. Jones, signing off.